The idea of combining senolytics with physical therapy represents a powerful, next-generation approach to chronic pain, one that doesn't just manage symptoms, but addresses both the biological root causes and the mechanical dysfunctions that perpetuate discomfort and disability. For decades, chronic pain treatment has been divided into two often disconnected paths: pharmacological interventions to control inflammation or mask pain, and movement-based rehabilitation to restore function. But recent advances in aging biology suggest that cellular senescence, the accumulation of aged, dysfunctional cells that promote inflammation and tissue degradation, may lie at the core of many chronic musculoskeletal conditions. If so, pairing senolytic drugs, which selectively eliminate these zombie cells, with targeted physical therapy could offer a synergistic, whole-body strategy for durable relief and recovery. Senescent cells have been found in joints, tendons, intervertebral discs, and skeletal muscle following injury, overuse, and with advancing age. They secrete a range of pro-inflammatory and tissue-degrading molecules collectively known as the senescence-associated secretory phenotype, SASP. This toxic microenvironment interferes with regeneration, activates pain pathways, and leads to structural weakening of connective tissue. Worse, senescent cells can spread their phenotype to neighboring cells, leading to a kind of local contamination that blocks healing even after the initial injury resolves. Here's where physical therapy often hits a wall. Despite excellent biomechanics and movement re-education, the tissue itself may remain in a biologically compromised state, inflamed, fibrotic, and resistant to remodeling. A chronically irritated tendon or stiff spine segment may not respond to exercise simply because the internal environment is still dominated by SESP signals. By clearing out senescent cells with senolytics, we may be able to reset this environment and make tissues more receptive to the mechanical loading, stretching, and proprioceptive retraining offered by physical therapy. On the other hand, movement itself has cellular benefits. Exercise is known to activate autophagy, improve mitochondrial function, and in some studies, even reduce senescence markers. In animal models, mechanical loading of tissues can enhance stem cell activation and stimulate repair pathways that reverse degenerative changes. This suggests that physical therapy could complement senolytics not only mechanically but metabolically, amplifying the regenerative window created by clearing out aged cells. What makes the dual approach especially promising is the timing synergy. Senolytics, by design, are given intermittently. Just a few days of dosing can lead to weeks or months of benefit. This creates a strategic window for physical therapy to take advantage of newly cleared tissue environments. For instance, imagine a protocol in which a patient with chronic knee pain due to mild osteoarthritis receives a 3-day course of senolytic treatment with Physidin or a dasatinib combo, followed by an intensive 2 to 4 week rehabilitation cycle focused on joint mobility, neuromuscular retraining, and progressive loading. This cycle could then be repeated quarterly, providing both molecular and mechanical renewal. Early animal data supports this idea. In studies of joint injury and cartilage degeneration, senolytic treatment improved tissue quality and reduced inflammatory signaling. When combined with mechanical stimulation, outcomes were significantly better than with either intervention alone. Similarly, in aged muscle models, senolytic clearance followed by functional training improved strength, coordination, and muscle architecture beyond baseline levels. The implication is clear. Senolytics unlock regenerative potential, while physical therapy directs it. This approach also offers important psychological and behavioral benefits. Many patients with chronic pain become discouraged by the slow pace or modest results of rehab. But if senolytics help reduce pain and inflammation more rapidly, they may increase engagement, motivation, and adherence to physical therapy, creating a virtuous cycle. Likewise, rehab professionals could use post-senolytic windows as peak opportunity periods to introduce challenging movements or restore higher levels of function. From a safety standpoint, the integration appears favorable. Natural senolytics like Physidin and Quercetin are well tolerated, with antioxidant properties that may actually support exercise recovery. More potent drugs like navitoclax or dasatinib require monitoring, but when used in intermittent, low-dose regimens, they have shown acceptable profiles in older adults. The key will be individualized treatment, matching the senolytic agent and rehab intensity to the patient's age, injury history, tissue status, and biological resilience. Future protocols could include biomarker monitoring, using markers like P16-INK, 4A expression, or circulating IL-6 to time senolytic dosing, followed by customized physical therapy modules targeting specific tissue deficits. Wearables and digital movement analysis could help track recovery trajectories, optimizing both cellular and functional outcomes in real time. In sum, combining senolytics with physical therapy isn't just a novel pairing, it reflects a shift toward integrative, systems-level thinking in chronic pain medicine. Instead of chasing symptoms or compensating for structural decline, we may finally be able to restore biological function at the cellular level and then guide that restoration with intelligent, movement-based care. For patients living with persistent back pain, joint dysfunction, or post-injury stiffness, this could be a transformative path, one that restores not only mobility, but resilience and quality of life far beyond what either intervention could achieve alone.